This video is on stomach pathology, and stomach pathology is a lot like pathology of your esophagus. Remember, we talked about pathology of the esophagus. We said things like acid-caused irritation and things like inflammation, and all that inflammation would eventually lead to complications. One of them being cancer. That was like the gist of esophageal pathology, and this is no different. This is kind of the gist of stomach pathology. So stomach pathology is the topic of this video. And a lot of it has to do with all that acid that is in your stomach. When acid hits your stomach, it will cause inflammation. We call that inflammation gastritis. What a great name. Itis meaning inflammation, so gastritis. And there are many causes. You can have acute causes, acute gastritis, and this can be if you take too much NSAIDs. And we said prostaglandins help decrease acid. And if you block that, then you'll have increased acid. You can have too much acid if you get a brain injury, if you have a traumatic brain injury. Why is that? Well, it seems that if you have a brain injury, especially if you have raised ICP, this can cause some sort of effect on your vagus nerve, and your vagus nerve works out of control. There's increased vagal stimulation, and that increases acid. How does that increase acid again? Well, let's go over our pathway. Here's your stomach. We said we had your parietal cells that released acid. And we said your vagus nerve was our great rest and digest nerve, really wanted to stimulate digestion, really wanted to stimulate acid release. So vagus nerve would stimulate parietal cells. Not only does that stimulate parietal cells, but it'll branch off and stimulate another cell called your G cell. Your G cell. And your G cell released gastrin. And gastrin helped stimulate the parietal cells even more. And gastrin also stimulated your ECL cells, ECL, which released histamine, and again that stimulated your parietal cells to release more acid. So vagus nerve stimulation has a ton of things to do with increasing acid. So if you have increased vagal stimulation due to some sort of brain injury, then you can have increased acid. You get gastritis. Another thing, you can have gastritis if you have ischemia. If you go into hypovolemic shock, you get ischemia, then the cells of your stomach will start to die. And a lot of times, it's not specific, you can have your parietal cells dying, but most of the times you can have your top layer, your protective mucosal cells die, and you get gastritis. So a patient comes in from having a severe burn patient comes in and then starts to develop severe epigastric pain. Why? Because that severe burn patient is undergoing hypovolemia and they're getting acute gastritis. So, all right, ischemia slash hypovolemia equals gastritis. These are all causes of acute gastritis, some chronic causes. You can have something called Zollinger-Ellison syndrome. It's called ZE syndrome. ZE syndrome is a syndrome where there's a tumor that's increasing gastrin. And we said how important gastrin is in producing more acid. So if you have a tumor that increases gastrin, then that will cause increased acid. And you can look for this because you can check the gastrin levels, and the gastrins are just uncontrolled. Yeah, you're having the tumor causing increased gastrin, just uncontrolled gastrin levels. But the most common cause of gastritis, of acid, of inflammation in your stomach is our good friend H.pylori. H.pylori. And you know what I'm going to ask you? I'm going to ask you to tell me everything you know about H.pylori. If you said it's a gram-negative rod, that's not good enough. If you said it's a gram-negative rod that has a flagella, that's getting better. If you say it's a gram-negative rod that has a flagella and just triple positive, then we're cooking. Then we're getting somewhere. All right. So H. pylori is a gram negative rod. It has a flagella that lets it move around, and it's triple positive. What does triple positive mean again? It means it's catalase positive, it means it's oxidase positive, and more importantly, it means it's urease positive. You see, urease turns urea, urease turns urea into ammonium and CO2. And that ammonium buffers the acid, and that's what allows it to live in our stomach. You've probably heard a great story about the person that discovered H. pylori. You know, way back when a whole bunch of people had stomach ulcers and all this gastritis and really epic gastric pain, but they didn't really know what caused it. And then someone came along and said, I think this bacteria called H. pylori caused it. And everybody laughed at him because they said, there's no way that can live in that acidic environment and live in your stomach. So he proved it by drinking a bunch of H. pylori and getting stomach ulcers himself. And so it can live in that acidic environment because it produces ammonia through urease, and it kind of buffers it. All right, so let's say this is your stomach cells. And your stomach will produce like a little layer of mucus to kind of help protect it. And then above that mucus is going to be all your acid. All your acid. H. pylori will come in with this little flagella. It kind of looks like a sperm, but it'll come in and it'll start producing this ammonia, kind of buffer that acid. And that allows it to penetrate and live inside your cells. And H. pylori will infect your cells, destroy your cells, cause inflammation of your cells. Now it looks like this. It just destroys your cell, and then all that acid will kind of go inside and cause gastritis. And H. pylori is the most common cause of gastritis. Now, person comes in, has epigastric pain. We say it's the most common cause of gastritis, but how do we know it's causing that particular patient's gastritis? We don't want to miss everything else, do we? So we have to test for H. pylori. How do we test for H. pylori? Well, we'll use this urease positive characteristic to our advantage. We'll ask the person to swallow some radio-labeled urea. Radio-labeled. And they'll swallow it. And H. pylori will turn that into ammonia and CO2, which by definition will stay radio-labeled. Radio-labeled. And they'll breathe out that CO2. Breathe it out into this apparatus, and we'll know, hey, there's H. pylori in the stomach. We call that the urea breath test. Breath test. You can also just do a stool sample. Just do a stool sample, look for antigens of H. pylori. And the patient comes in with epigastric pain, you do your breath test. They have H. pylori. How do you treat it now? How do you treat it? So the treatment for H. pylori, let me write it up here. The treatment for H. pylori, Rx, is going to be something called triple therapy. Triple therapy, and we call it triple therapy because you have two antibiotics and the proton pump inhibitor, PPI, kind of reduce that acid. The two antibiotics are going to be your amoxicillin and clarithromycin. And that's triple therapy. You give that to them, and hopefully it gets better. If it doesn't get better, then we kind of have to up our ante, and we give them quadruple therapy. Quadruple therapy is going to be two antibiotics and a PPI and bismuth. We talked about this in our previous video on pharmacology. What does that do? That binds to the ulcer base, kind of helps it heal. What are antibiotics that we're going to give them? Well, we can't give them amoxicillin, clarithromycin. We just tried that and it didn't work. So we have to give them something else. We'll give them metro, and we'll give them tetracycline. All right, so we try different type of antibiotics and we add bismuth, and hopefully that works. Now we just talked about all these things that can cause increased acid, increased inflammation. What's the complication of all that? What are the complications of all that increased acid, increased inflammation? So let's draw our epithelium. And let's say our acid is now, there's too much acid and it's getting exposed to our epithelium. And that acid can erode the top layer, our mucosa. And if it erodes our mucosa, we call, erosion of mucosa, we call those erosions. But, I mean, it won't just stop there. It'll just continue to erode, and start involving our deeper layers. There's submucosa or muscularis externa. We call those ulcers. So if it erodes your, submucosa plus other layers, we call those ulcers. That's what ulcers look like, don't they? So we call those ulcers. Now, 70% of ulcers in the stomach have to do with H. pylori. We say that's the most common. So, 70% stomach ulcers equals H. pylori. Something you should know, we're just talking about stomach pathology for now, but something you should know is that H. pylori doesn't only affect your stomach. It can go in and infect your duodenum, cause duodenal ulcers. In fact, 90% of duodenal ulcers are due to that stinking bug, that stinking H. pylori. All right, so it causes a ton of these ulcers, and a ton of acid can get in here. And like I said, acid doesn't just stop there. It can keep going and going and going until it literally blows out your entire stomach wall. So complications of ulcers include things like perforation. So it basically perforated your stomach wall. And that's not good, because here's your diaphragm. If it perforates your stomach wall, then you can have free air under the diaphragm. So, air under diaphragm. And it can irritate your diaphragm. And anytime you irritate your diaphragm, irritate your phrenic nerve, you have referred pain. Referred pain where? If you said shoulder, very, very good. Referred pain in your shoulder. Another complication is hemorrhage. Your ulcer can bleed, and that blood can get incorporated into your chyme, your food, and you poo it out. There's blood in your poo. We call it melena. So melena or melena. It can also, like I said, perforate and involve nearby blood vessels. So there's a blood vessel here, and it can perforate and involve that blood vessel and cause that to bleed. If it perforates your lesser curvature, then it can affect the blood vessels in your lesser curvature. What do we say those were? Those were your gastric arteries. In particular, it likes your left gastric artery. Left gastric artery. If you're affecting your lesser curvature. If you're affecting your greater curvature, what are the vessels here? These are your gastroepiploic arteries. So gastroepiploic. If you're affecting the greater curvature. So those are all ulcers in your stomach. We say ulcers also affect your duodenum. So your duodenum. And in particular, there's this artery that lies behind, posterior to your duodenum and your stomach. We call that your gastroduodenal ulcer. Gastroduodenal artery. What a fitting name. And if you have a duodenal ulcer that perforates and involves that vessel, then you can have hemorrhage via the gastroduodenal. And that's from duodenal ulcers. All right. So these are all complications of ulcers. Now I just want to take some time to compare and contrast duodenal ulcers and gastric ulcers. All right, just to make sure you can tell the two apart. That way you can tell them apart via the question stem. All right. So some things that are different between duodenal and gastric ulcers. Duodenal ulcers have a higher association with H. pylori. We said 90% due to H. pylori. We said 90% of duodenal ulcers are due to H. pylori via 70% of stomach ulcers. So it has a higher percentage due to H. pylori. So more associated with H. pylori. Duodenal ulcers, also the pain is relieved by eating. Why is the pain relieved by eating? As opposed to stomach ulcers where the pain gets worse with eating. Why is that? Well, when food hits your stomach, your stomach's natural reaction is to produce acid. Yeah, digest that food, and all that acid is going to basically make your ulcers hurt more. And so stomach ulcers get worse with food. However, once that food goes to your duodenum, when food hits your duodenum, what does your duodenum do? Your duodenum releases a lot of enzymes to help break that food down. It also releases a lot of bicarb to neutralize the acid. That bicarb is like soothing. It's like a saving grace. That bicarb will neutralize the acid, make things better. You get relief with food. So pain is relieved by eating in duodenal ulcers. And then last but not least, look at our pathway. Acid causes inflammation, causes complication, plus cancer. Duodenal ulcers are less associated with cancer than gastric. All right, so gastric ulcers follow this pathway a little bit more and can lead into more cancer. All right, that's just a little compare and contrast, and a good segue to our final topic, which is cancer, gastric cancer. We said you have things that increase acid, causes inflammation, that leads to complications, including cancer. How can you tell patients? I guess, like in the question system, how can you tell a patient is suffering from gastric cancer? Well, they're going to have gastric pain, and then all of a sudden that gastric pain gets worse. They get weight loss, they get early satiety. Those are all signs that might clue you in the question system that maybe you might be thinking of gastric cancer. So I'll say, have a gastric pain, weight loss, and the big one they always include is early satiety. All right, there are many different types of stomach cancers, but there are only 3 types I'm going to talk about. So there are 3 types, and 2 of them have to do with H. pylori, our good friend H. pylori. So let's say 2 associated with H. pylori. And one of them is called the intestinal type. Just like your esophagus, anytime there's acid that's affecting your cell, your epithelium will freak out, yeah? And we said that in your esophagus, it freaked out and there went metaplasia, turned into an intestinal type. It turned itself into columnar with goblet cells. Recall that? We call that intestinal epithelium. Well, your stomach's not different. It'll freak out from that acid and turn itself into intestinal epithelium. And so we call this cancer intestinal type. Sometimes we call it adenocarcinoma. Now, what does it look like? You can't really tell the difference between this and just regular ulcers. It looks just like an ulcer. All right, so you have to biopsy all ulcers to make sure they're not intestinal type adenocarcinoma. The second type is MALT lymphoma. What the heck is MALT? MALT stands for mucosa-associated lymphoid tissue. Mucosa-associated lymphoid tissue. You see, you have these little collections of lymphoid tissue all over your body, including your mucosa. And if H. pylori goes in and infects them, increases cell turnover, then you can have cancer of these lymphoid tissue. And anytime we have cancer of lymphoid tissue, we call them lymphoma. So you can get MALT lymphoma. Lastly, our last type of cancer that's not associated with H. pylori is going to be called the diffuse type. The reason we call it diffuse type is because it affects the entire stomach. It doesn't just show up as an ulcer. It doesn't just affect little parts of lymphoid tissue that you find in your stomach. No, it affects the entire stomach. And you can see it grossly because the entire stomach now looks like leather, looks like a bottle, like a leather satchel. So it affects the entire stomach. They can show you a gross picture of the stomach that looks like leather, say nothing more, and you should be able to tell it's diffuse type cancer, gastric cancer. That's what it looks like grossly. What does it look like microscopically? Well, all your cells are going to get full of mucin. And all that mucin is going to push your nuclei to the periphery. Push your nuclei to the periphery. Now all your cells with the nuclei on the periphery look like this. Sometimes we call it looks like a diamond ring or a signet ring. Signet ring. Again, pathognomonic. They can just show you a picture of cells that look like this. Say nothing more. Say nothing more. And you should be able to tell, oh, that's diffuse type gastric cancer. You gotta know those cold, all right? Now, gastric cancer doesn't really have a good prognosis, and a lot of times it presents late with metastasis. Let's talk about how you can recognize metastasis of gastric cancer. So, all right, recognize metastasis. Recognize mets. The first example is Krukenberg tumor. Krukenberg tumor is when the cancer spreads to your ovaries, especially bilateral. So bilateral ovaries. So a patient will come in, long-standing history of epigastric pain, and then all of a sudden now they have pelvic pain, bloating. You do a pelvic exam and then you can feel two enlarged masses and you find out they have a tumor in their ovaries. You biopsy that tumor, and you see these. Dead giveaway. Absolutely dead giveaway. There is no ovarian, there's no primary ovarian tumors with these type of cells. All right. That's Krukenberg tumor. And I've been asked that many, many times, not only in step 1, but step 2. Okay, so you gotta know that. Second example is eruption of dark pigmented skin lesions. You can have eruption of acanthosis nigricans. What is that? That's that dark velvety skin that you see in a lot of folds, so the neck folds, axilla, places like that. And you might be saying, isn't that associated with type 2 diabetes? You're absolutely right. So you can see it normally in patients with type 2 diabetes, but if you don't have that and all of a sudden there's an eruption of it, you're thinking of gastric cancer mets. Why it causes that? No one's really quite sure. You can also have an eruption of a different type of dark pigmented skin lesion, and this is seborrheic keratosis. That's that kind of warty, brown, gummy looking thing that you see in a lot of old patients. And again, it's normal. Yeah, you have a few of them, not really a big deal. But again, if you have a sudden eruption of these, you're thinking gastric cancer. So I'll write sudden eruption. So if you see it, just 1 or 2 of them, don't scare the patient and say you have cancer. But if there's a sudden eruption, then you're suspicious. Third example, Burkhardt node. This is an enlarged left supraclavicular lymph node. So enlarged left supraclavicular lymph node. Why is that node enlarged? Because your stomach and a lot of these organs down here get their lymph drainage by the thoracic duct. And the thoracic duct goes up and will link to your left subclavian. So go up your body and then link to your left subclavian. And if you have mets there, you can have that enlarged left supraclavicular lymph node. We call that Burkhardt node. So it gets drainage by your thoracic duct, where it links up to your left subclavian, and spread there can cause this enlarged node. Last but not least, Sister Mary Joseph nodule. This is when the gastric cancer spreads to your abdominal region, so much so that you can actually have a protrusion of cancer literally through your umbilicus. You get this nodule literally through your belly button, and that's just cancer. So all right, umbilical nodule. You should be able to recognize these easy. And that does it for this video. Hopefully that clarifies stomach pathology. See you next time.